Uh, Hello, everybody. I would like to welcome you to our second seminar for extracorporeal circulation. This lesson is dedicated to ECMO. I believe it is a very interesting topic, and our presenters are also really exceptional. We have the honor to have with us Professor Angouras Dimitrios, who is a professor of cardiac surgery in the National Kapodistrian University of Athens in Attikon University Hospital. Dr. Angouras, welcome, and please, let's start our meeting.
Well, thank you very much. That's the, as you said, the second seminar of the second series of seminar. This third series, actually, yes, third series of seminars. Congratulations for this effort. This is fantastic for our perfusionists. As you said, a very interesting topic today: extracorporeal membrane oxygenation. Do not expect to learn everything from this lesson, but expect to learn a lot. Be as interactive as possible, because we have very experienced perfusionists and surgeons as speakers and commentators. So it's expected to be very, very interesting and educational session. I have the pleasure to co-moderate this session with Dr. Dimopoulos, a very experienced in ECMO intensivist from the Onassis Cardiac Surgery Center. Actually, it's Onassis Hospital now. So I will ask you, Dr. Dimopoulos, to present our first speaker. Thank you.
Thank you very much, Professor Angouras. It's a great pleasure for me too to be here and participate in this excellent seminar. As just a brief introduction, to say that Greece is a country that it is under developing the ECMO program, the ECMO service, and I have to say that in the last few years we have done quite a lot, and Onassis Hospital in particular is the only active ELSO center that we have in Greece. Hopefully we'll have more in the future, and we are trying to offer this service to at least regionally in Athens and nearby, with assistance of Attikon Hospital, where Professor Angouras is working, and another hospital, Evangelismos, the biggest one in Greece. So I would just say that our numbers are quite good at the moment, and the last 2 years we have increasing a lot our volume, and we have increased also the rate of good outcome. We have an ECMO fellowship program, ICU fellowship program, and we have an ECMO training program that is running the last few years. And I am really delighted that this hospital here has been organizing this excellent perfusion training webinar. So after this delay, I am also very delighted and happy to introduce Lisa Carson-Price from University Leicester Hospital. She's a perfusionist, deputy, actually principal perfusionist at the University Hospital Leicester, and she will provide us the first lecture, which has to do with the ECMO physiology and techniques. So your talk is now for you, Lisa.
Thank you very much. Can you hear me?
Yes, we can hear you very well. Thank you.
Wonderful. Well, thank you for the invite to talk on ECMO physiology and techniques. So I know you've done previous webinars, one covered ECMO. So I'm hoping this will give you a little bit of a different perspective than the last presentation, with a few additional bits. So I think before we talk about ECMO, we need to talk a little bit about what normal cardiopulmonary physiology is and understand why we use ECLS devices or ECMO devices. So all tissues of the body function by combining substrates with oxygen, producing heat, energy, CO2, and we refer to this as the metabolic process. And metabolism is very closely related with oxygen consumption, and it is determined by measuring the amount of O2 consumed per minute, and we refer to this as VO2. So if we look at the table on the left, at rest, adults consume 3 to 5 mils per kilo. per minute or 120 cc's per minute per meter squared. But this demand can obviously change depending on what is going on with the patient, whether they have a disease state or whether they're exercising or whether there's hypothermia involved. Now, the amount of oxygen delivered to the tissues in the body is calculated by multiplying the oxygen content in the arterial blood by the cardiac output and is referred to as DO2. And I'm sure this is all, we should know this really, but I always like to start at the very beginning. And for a normal adult, this is normally about 600 cc's per minute per meter squared, or the equivalent consumption by weight can be seen on the graph as well. Now, this is controlled, this ratio of DO2, VO2 is controlled by the hemostatic mechanisms. And normally we try to maintain that the supply is 5 times the demand of the VO2, so that the body's hemostatic processes adapts according to what's going on to try and keep this ratio in mind. And I think we have to bear this in mind when we're thinking about, when we are trying to use ECMO. Now, if the demand rises, as I said, the body will try and increase the ratio. If the body for some reason cannot do this for whatever reason, if there is a mismatch, the body can tolerate this pretty well until a ratio of less than 2:1 is reached. And it's at this point when there isn't enough oxygen to maintain aerobic respiration, and the body can only tolerate this for a few hours, and ultimately results in systemic acidosis and organ failure. And naturally, this is what ECMO or ECLS is trying to prevent. We're trying to not go into this dangerous territory. So, next slide. So how do we use ECMO or ECLS to support this situation? So if we think about the patient's respiratory system, or cardiovascular system, they are circuits that are oxygenating, T-carboxylating and providing flow. And an ECMO circuit is simply an extension of the patient's own circuit, and it allows us to take over, isolate or support those native roles that the heart and lungs do. Now, the supporting function of the ECMO circuit depends on the vessels the ECMO circuit is attached to, and which vessels we choose to attach the ECMO circuit to is determined by the reason we require ECMO. So respiratory issues, the ECMO circuit is used in series with the patient's circulation. So blood is drained from a vein, returned to a vein, and it's what we refer to as veno-veno ECMO. And for cardiac issues, the blood is drained from a vein, returned to an artery. So the ECMO circuit is working in parallel with the patient's own circulation. And then this is what we refer to as VA ECMO. However, irrelevant of what we're using ECMO for, the components, the circuitry is exactly the same. We just need to be aware that it has to meet the demand or the metabolic demands or this ratio of 5:1 that we want to try and achieve. So let's look at how we select our device. So like I keep mentioning, we must select devices that will be able to sufficiently deliver and meet this metabolic demand requirement. So we have to be able to add oxygen and remove CO2. So that will be the role of our membrane lung or oxygenator. And we need a pump that can either drive this process or provide cardiac output. So we need to have a pump that's of appropriate size and power. And whilst doing this, we need to bear in the back of the mind that this circuit has to have a heat exchanger so we can help control body temperature. We want to minimize priming volume, so obviously to minimize hemodilution, and we'll come to why a little bit later on. And we want to prevent areas of stasis and low flow and stagnation, because obviously the circuit will clot off, and we absolutely don't want this because we cannot provide the support we require. And then further consideration should be given to surface activation. We need to try and minimize the activation of our clotting products and the inflammatory response by minimizing the circuit and maybe considering coatings of the circuit. So how does the membrane lung work? So what's the physiology of this membrane lung? So the PMP fibers, polymethylpentene fibers, act as a semi-permeable membrane where gases move from high concentration to low concentration. So oxygen, as we're probably aware, moves from the high concentration within the fibers to the blood section beyond the fibers. And CO2 conversely works along, moves across concentration gradient in the other fashion. So CO2 is high on the blood side and it's low on the gas side. So we'll move into the middle of the fibers and out through your exhaust. Now, the amount of gas transfer that happens depends on numerous factors, which we'll discuss on the next couple of slides. So the following things affect oxygen transfer. And the reason we talk about this because we want to know how it works, and we need to bear this in mind when we're constantly trying to maintain this goal of DO2-VO2 ratio. So firstly, we have to think about the surface area of the fibres within the membrane lung. As surface area increases, then so does the amount of O2 diffusing into the blood. Makes sense. Until that surface area becomes saturated, which we can see on this graph. I don't know if you can see my pointer here. Is it going to work? So, which we can see here. At this point is when the surface area becomes saturated, and we can no longer, provide any further gas exchange, or increase the gas exchange any further, should I say. Secondly, as flow increases, more red blood cells come in contact with the gas exchange surface area. So within a given time, more oxidation can happen. So more flow equals more gas exchange for more movement of O2 into the blood phase. And then finally, hemoglobin levels. And it makes sense, doesn't it, really? The more red blood cells, the oxygen transporters of our body, there are available to carry oxygen to the tissues, the greater the transfer. So moving on to CO2. So CO2 transfer occurs in the membrane lung fibers at a much faster rate, basically because the CO2 solubility is much greater than that of oxygen. However, the factors that affect CO2 removal are primarily the concentration gradients between the gas side and the blood side of CO2. The greater the difference in those concentrations gradients on either side, the faster the removal of CO2, which we can see in this first graph here. Then blood flow. Now, blood flow has a much lesser effect of removing CO2, but there is a slight increase. So as we increase our blood flow, there is a slight increase in CO2 removal. And then finally, I suppose, like the biggest bear or influencer of CO2 removal is our sweet gas flow rate. So as we can see in this graph here, it quite exponentially rapidly increases. The more sweet gas flow rate, the more CO2 removal that goes on. As a result of these properties, the CO2 and oxygen that was removed is done the following way. We can summarize it into, if we need to increase oxygenation, we increase the blood flow. If we need to increase the CO2 removal, we can increase sweet flow rate. And they're the main drivers of gas exchange within our membrane lung. So we must remember that ECMO is not an ultimate treatment, but it's a mechanism to buy us time. And so with that said, the following principles must be remembered, and the clinical presentations that we'll see in the next page must meet this criteria. So, ECMO is going to buy us time. So whatever we are going to treat, the patients we're going to treat, we must have an etiology or reversible pathology. There are risks associated with ECMO. So the disease state or the patient is in must provide a greater risk than if we provide ECMO support. And then finally, ECMO can be used as a bridge to decision making. So a bridge to recovery, a bridge to transplant, again, just to buy us time. So what patients do we see this temporary mismatch between oxygen delivery and oxygenation demand? So the following disease states are stated in the ELSO guidelines. So if you look for VA ECMO, it is frequently used for cardiogenic shock, in failure to read from cardiopulmonary bypass, and for in cardiac arrest. Now, these are all whole lectures in themselves, so that's a bit of homework for people to go away and read up about. And again, with our respiratory side, our veno-veno ECMO, there is criteria which we can use for. So when the oxygenation hits a certain level and that mechanical ventilation becomes injurious, that's when we want to use it in the respiratory population. Also for CO2 retention, which we see in our asthmatics, and then also in situations where we might not be able to intubate a patient and need to provide gas exchange, such as the patients that have lung transplants. And then finally, in those patients that have PE. And ultimately, the goal isn't it, of ECMO, is to basically increase that supply of oxygen to try and recreate or make sure the DO2-VO2 ratio doesn't fall below a 2-to-1 ratio. So there we go, a brief synopsis or summary of why we give VV ECMO. So increasing systemic oxygenation and CO2 removal, so we don't use to use damaging ventilation. And for VA, it's when systemic oxygenation and CO2 removal and circulatory support is required and the body can't maintain it. So I've talked about the circuit and how we're going to do it, but we must talk about cannula. And cannula is often the underrated, I think, component when we talk about ECMO. It's given the least sort of information about. So where we place the cannula will impact which cannula we use naturally. And the selection we have, or the selection we take, will have a tremendous impact on the ability to be able to provide good ECMO, to provide sufficient support and efficient support as well. And your patient will only recover, obviously, if we can provide this adequate support and allow failing organs to recover. So if we think about it, our drainage must be big enough, or the diameter must be big enough to get enough volume from the patient so we can provide the forward flow that we need. And then the return cannula can't be too small so that we are able to achieve the desired flows required, which we'll touch on in a moment or two. And bearing in mind, we can't just run at incredibly high flow rates with very high pressures, because this in turn will cause damage. So we must appropriately size the cannula. And also, if we have an arterial cannula that is too big, or a return cannula that is too big, the flip side of that is that we can get vessel occlusion and cause damage to the limbs if we're using the limbs as our point of access. So what cannula options are available to us? So we have VA ECMO, which is commonly used for our post-cardiotomy patients requiring, support of the heart and lungs. Perhaps the heart is stunned after a long cross-clamp time, so on and so forth. Now, the easy option in these patients is obviously to use the chest is open and to use the central cannulation option. We have clear visibility of the aorta and of the SVC or the atrium, and we can use those positions to cannulate. Or if the intention, or this is for an ECPR, or the chest isn't open, we can use a peripheral approach. And we can either use the femoral artery and the femoral vein, so femoral artery naturally to return and femoral vein to drain, or we can use a combination of a right internal jugular and a femoral vein and return to the femoral artery. So there's a couple of configurations we can think about. The important thing is that when we're doing this, we have to be able to deliver the right amount of blood flow. So that has between 3 and 6 litres per minute. And we have to be mindful of various points, or various things where we're delivering VA ECMO. We need to look at the right radial arterial pressures, blood gases, and the right side and the left side to detect if we've got any differential oxygenation going on. We need to be mindful, obviously, of what the LV is doing and contractility. If the heart isn't contracted, the heart can become distended, or the left side, and we can cause serious damage. And if there's very little flow coming out of the heart, we can also have clot formation. So in these sorts of situations, we need to think about venting options. And again, this is a whole lecture in itself. We can put a vent in from a circuitry point of view, or can use such things as intra-aortic balloon pumps and impeller devices. And our goal is there stated at the bottom. With these cannulations, particularly if we're going femorally, as I alluded to earlier when I was talking about appropriateness of cannula selection, it's wise to put in some form of leg perfusion. We don't want to do a wonderful job of helping this patient recover, and then the limbs become ischemic and require amputation in a worst case scenarios. And there's many techniques that can be used. We can use a sheath that's plumbed into the circuit using a corded sheath, or you can use a pediatric cannula to put in situ. And it's often advisable to actually, if you're putting guide wires in, to put these guide wires in first, because these small vessels can go into spasm. Let's move on to VV ECMO. So we alluded to VV cannulation is primarily used for respiratory support, and the common configurations are there on the screen in front of you. So we can have contralateral or unilateral femoral vein configuration. So either the access and drainage are in the same side, or opposite sides. There's lots of debate which one's better or not, and I don't think anything has definitively been proven. And then there's also the option of using the dual lumen venous cannula, which is this one here, which is nice from a patient point of view because it's from a surgeon, and in each this point of view, it's one cannulation, isn't it? One cannulation site, less risk of infection, but is a slightly technically more challenging and can't be done using Seldinger technique. Again, we need to bear in mind that actually what our goals is obviously to maintain oxygenation to these levels down here, and that will require less flow than we require in VA ECMO, but we also have to be mindful that we may experience recirculation, and this is something that we need to, if you like, play with the flows to ascertain whether we have recirculation or not. So moving on from VV ECMO, I've talked about kind of the common cannulation sites, the common ways of doing it, but there are many other options when we're dealing with respiratory support. So if we look at this this diagram, so it is one taken that I've then added to. We can use VA ECMO for respiratory support, particularly if we have failure of any of the ventricles, especially if it's left ventricular failure. VA ECMO may be useful, or if the right ventricle is failing, again, that increase in oxygenation might offload the right ventricle a little bit more and may be useful. The problem with VA ECMO is obviously it's not without its risks, particularly for the central nervous system and that side of things. So if we have a failing right ventricle, there is the option to obviously use venopulmonary artery ECMO, which is kind of the new kid on the block, and there's lots of exciting things going on about that. I'm just going to touch on it briefly. So here is some VPA ECMO, and the idea is that we're draining from the vein and returning the blood back to the pulmonary artery, bypassing essentially the ventricle, the right ventricle. And the reason we might do this is because it's stretched, dilated, and overloaded. And then by bypassing it, we basically offload it whilst maintaining oxygenation. Now, naturally, you say, oh, we could use a VAD, but no, this is right ventricular failure in the presence of hypoxemia. So what do we do? How do we maintain the VPA? What are our target goals when we're on VPA ECMO? It's no different to V ECMO, but we must be more mindful of venous congestion. So we need to be mindful of the renal veins and the hepatic veins. And then also we need to be mindful of any changes to the right ventricle, so any coupling issues between right ventricle and left ventricle. But other than that, we treat it at the bedside very much as the VV situation. So how do we know if we're achieving our ECMO goal, our supply of oxygen that is 3 times greater than the demand? Well, I touched on it earlier. There's some lovely calculations that we can use. So in VV ECMO, it's a little bit more difficult because we don't fully know what the systemic SaO2 is, because we have native lung flow. We can have recirculation. We're also relying on the fact that the cardiac output is actually the patient's cardiac output. So so the saturations is influenced by all these things. Now, if we look here, we can calculate the delivery by using this interesting equation. So we can get the shunt fraction, the amount of fluid blood going to the lung, and we can use that with the mixed venous gases and plug it into the equation and get a lovely number. But actually, in assessing whether we're doing a good job, there is much easier ways of doing it. We can look at our DO2, we can look at our lactate, we can look at all the other signs of hypoxemia, so urine output, etc. And our goals are detailed here below. For VA ECMO, how can we calculate if we're doing giving enough, achieving our goal? Well, delivery, again, is a cardiac output times the arterial concentration of oxygen minus the mixed venous content. So essentially it's pump flow minus times these two components. However, a very easy way to think about it, because we don't have the complications of native lung and we don't know how much is going through the lung and the oxygenator like we have in VV ECMO, we can see if the venous saturations is 80, arterial saturation is 100. That's 28% used by the tissues, and thus the ratio is 5:1. So we're absolutely achieving our ECMO goal of a demand ratio of greater than 3. So adjusting your flow to above 66% is sure enough way to ensure that. However, if we're doing all these things and our goal is not there, we are not achieving our goal, our ratio, we need to try and correct the hemoglobin, which we had touched on earlier. We need to optimize our ECMO flow or reduce circulation. So that, again, that's about playing with the flows. There is a point which we're limited by the cannula, and in particularly in VV ECMO, you know, there comes a point where more flow equals more increased recirculation, which is a problem. And the other thing we can look at is obviously increasing our cardiac output with inotropes and volume. But what do we do if that doesn't work? So we can use these hybrid configurations. So in this situation, this is a situation we'd use VVA in different formats. So either draining from the neck and the groin, or draining from both groins, or in this situation is where we might have instigated an ECMO for respiratory purpose, and then the heart or the cardiac output would start to fail, and we might have to introduce an arterial situation. And in this situation, you have 3 access points for drainage. So why would extra drainage be beneficial? We know that actually the extra drainage gives us the capacity to deliver more flow. Okay. We might have a patient perhaps has very strange anatomy, perhaps a congenital patient that has very small vessels for whatever reason. So we might need triple venous cannulation. So the point of this is actually what we do to meet this metabolic demand is constantly dynamic and changing. The patients will change as the disease progresses, and we must be able to adapt to meet those demands. And again, another form of hybrid configuration is where we can use VA-V ECMO. So it will depend the change on what our initial ECMO was. So if our initial ECMO was VA ECMO, and a patient then begins to experience the cardiac output becomes compromised, we can then convert to this situation. And as above, this is another version of this. So the use is as extra drainage, but the cannula will allow, extra drainage cannula will allow for higher flows over lower pressures. In my organisation, this isn't a difficult task. We have a nice bit of kit here that we have a Y connector with all sterile, ready to go. And using this sort of equipment allows to briefly pause while we insert a limb into our tubing. And then when we're ready to connect the additional limbs, either on the drainage side or return side, we can. So we have 2 short pauses, which hopefully won't destabilize the patient. So I appreciate I'm running a little bit over time, so I'll whiz on. So as I said, because we want to try and achieve this goal of oxygenation, and we have to be dynamic according to what's going on with a patient, we need to have a good range of cannula to be able to deliver hybrid or VV, to be able to cannulate either the neck or the groins. So we have to have a range of cannula, short, long, many holes, short holes, dual lumen to be able to do that. And I appreciate as a perfusionist, not everyone is a cannula expert. So in our organisation, we've come up with a little short colour coding thing, and it's kind of Elisa's top tip for the day for the perfusionists out there. Label things so people, in a very easy manner, so people can determine very easily what cannula they can use to provide the necessary support. There we go. Thank you very much. It's been a pleasure. I hope it was a little bit different to your previous lectures, and perhaps you've learned some techniques that might be useful in your own.
Thank you very much. Really an excellent presentation. In a brief period, you have summarized the main elements, and not only about how to implement ECMO and ECMO configuration, ECMO hybrid configuration, and the basics for physiology point of view. So we don't have so many questions. However, we have Christos Kalaridis, I think, that he might want to have a comment or a question. Do we have Christos? Yes.
Yes, Kalispera. Good evening, Lisa. Your talk was excellent. We just started a perfusion school here in the United States in Virginia, and I'm gonna make sure I have a copy of your talk because it was a great overview of ECMO and the limitations of ECMO, and its patient selection is also very important. So it's not only about, as you very well stated in your presentation, it's not only about putting patients on ECMO, it's selecting the right patients to put on ECMO. And bigger cannulas are not necessarily better. So I think that your overview was excellent, and it breaks the ice for the other experts that we have that are going to be giving talks on ECMO as well.
Lovely. I really appreciate your comments. And you're right, you know, bigger is not always better, even though generally as a perfusionist, that's what you say. But, you know, there may be benefit in using more than one cannula, but smaller ones. So obviously you get distal perfusion. So, but thank you for your lovely words.
You might be limited, you know, we might be limited as perfusionists to what we can put in at the moment. You could have a patient who crashes on ECMO, and at some point as a surgeon and as a perfusionist and as a intensivist, you might need to adjust your cannulation strategy to improve the drainage. As we all know, ECMO is a preload and an afterload determinant therapy. So I think if we have those basic concepts as practitioners, I think we understand a lot about ECMO as well. Thank you so much for that excellent presentation of ECMO.
Thank you.
Thank you very much, Christos Klaritis from US, and we're really glad to have you today. So many questions I would like to make, but the time is pushing us to the next lecture that we will have. So Professor Agouras will introduce our next excellent, eminent speaker.
Thank you. It's our pleasure to have with us today Professor Jill Gilles. I'm sorry. He's not connected. He's not connected.
Okay. So the next speaker will be
then
Marta Antonini.
Okay. Well, then the next speaker then will be Mrs. Antonini, Velia Marta Antonini. Mrs. Antonini is a cardiovascular perfusionist. She works at the University of Bologna in Italy. She's part of the ECMO team there at the Buffalini Hospital, and she's an experienced perfusionist. She's going to talk to us about very useful hands-on things about ECMO, such as the circuit management before and after ECMO, pre-priming and returning residual volume, pro, con, and strategies. Very, very interesting topics. We're looking forward to your talk. Hello.
Hello.
Thank you for being with us.
Thank you for inviting me. I'm really honored to be here with you and to provide this talk that I hope could be useful for maybe not so experienced perfusionist. So let's talk a little bit about managing the circuit, the ECMO circuit before and after ECMO. I have no disclosures with referral to this specific topic. So I will start with a topic which is absolutely actual. It's a debated topic, which is pre-priming. What is pre-priming? Pre-priming means preparing your circuit before the real use and priming the circuit in advance. It's something that it's becoming absolutely common in a lot of hospitals, in a lot of countries. Why? Because we have a lot of perceived benefits about this practice, meaning that if you go for pre-priming, it is commonly perceived as a faster strategy to be able to initiate ECMO and an easier strategy to start ECMO, particularly when you need to provide ECMO in an emergency setting, like, for example, in the setting of extracorporeal cardiopulmonary resuscitation, ECPR, or maybe when you have a complication, an emergent complication at the bedside, when you need to go for an emergent circuit replacement. If you have your circuit ready at the bedside, or maybe in the ICU or in the OR, it's easier, particularly for centers not having a perfusionist at the bedside 24/7. So they at least have the machine and the circuit ready for the emergency. If you prepare the circuit in advance, if you prime the circuit in advance, you could go for a meticulous procedure. and you can perform your priming in a quiet environment, which is absolutely different compared to preparing the circuit during the emergency. Preparing the ECMO circuit, it's normally easy. It's not like preparing a CPB circuit, but when you are in an emergency setting, when you have an high cognitive load, when you have a lot of stimuli arriving at the same time from different persons, because maybe the surgeons or the intensivists are asking you also about the cannula, the device to support cannulation, and a lot of different things. Also, being required to prepare the circuit increase the risk of errors and mistakes. While if you go for pre-priming in a quiet environment, you can decrease the risk for errors like slips and lapses, meaning execution failures, and you can also try to reduce mistakes, so planning failures, because again, you can follow a checklist, you can check the circuit before using, so it's a completely different setting, particularly when you need to start ECMO in emergencies. And you can also try to avoid what is called violation. Violation is a specific kind of error that you commit, maybe if you are really experienced and if you think that you can skip some steps in the priming and preparation procedure. Sometimes you can do this, but sometimes violation lead to major complications. So with the procedures like pre-priming performed in a quiet setting, you can avoid also this kind of problems. Moreover, when you go for a pre-preparation, you can have all the time that you need, so you can have a really clean procedure. You can wash properly your hands, you can prepare everything in a dedicated room, you can dress personal protective equipment, which also, like sterile gloves, are not strictly required for ECMO, but can decrease the risk for contamination. So it's something that could be absolutely useful. So we have a lot of pro about pre-priming your ECMO circuit. What about the cons? Because it's a debated strategy, so we need to understand the potential associated risks. First, the concerns. It's definitely an off-label practice. What does off-label mean? Going for a pre-preparation and pre-priming, maybe days before the real use in an ECMO setting, goes absolutely beyond what the circuit instruction for use that the producer provide with your circuit, and also goes absolutely beyond the prescribing information of the solution that you use for pre-priming. The prescribing information is in the European setting is defined the summary of the product characteristics. The solution that we use for priming are not supposed to be used to be open days in advance. So this is absolutely real. This practice is off-label. And when you do something in an off-label setting, you are taking the responsibility of the potential risks and damages that came with this kind of procedures. And moreover, we lack standards for this procedure. Even if it is becoming really common, we don't have standard for the practice. What are the potential risks associated with pre-priming? The major concern is potential for contamination. Potential for contamination of the circuit and of the priming solution. Then we are going to administer to the patient. Potential for impaired function of the circuit and potential for plasticizer release from the circuit to the priming solution. But we are lucky because being this practice becoming really common, a lot of groups started studying about the potential risks and potential safety of this kind of procedures. Let's start with contamination. A lot of studies try to assess the risk for contamination of the priming solution and of the circuit. We have a lot of studies performed throughout the recent years, and all these studies going for non-culture-based techniques, so looking for the DNA of the bacteria, but also culture-based strategies, were not able to find any kind of bacteria or fungi inside the priming solution after a prolonged period. What is prolonged period? Depending from the study, it's beyond between the 7 and 65 days, so it could be a really long period. These are experimental studies done with a smaller group of circuit between 4 and 10 circuit, but we recently had also larger studies that have been published. Two that I've cited here were published in 2024. These studies included between 100 and 230 circuits, so a lot of circuits. And these studies were not in an experimental setting, because these studies started to assess circuit used for clinical practice. And in both of these studies, they found a minimal level of contamination between 57 and 73 days of maintenance of the circuit after pre-priming. What I mean for minimal contamination, in the study by Renghini, published in Asaia Journal, the authors were able to find a 0.3% of circuit with contaminated priming solution. And in the other study, they were able to find 1.9% of circuit with contaminated priming solution. But you need to consider that they went for a really extended incubation period, and that the bacteria that they were able to find in the priming solution can be perceived as contaminants with no potential for a clinical impact on the patient. So maybe it's better to upset this kind of contaminants rather than delay ECMO initiation in an emergency setting like an ECPR, or rather than delaying the replacement of the circuit if you have an emergent complication leading to a prolonged period for the patient without ECMO, which maybe it's risky if the patient is completely ECMO dependent, or maybe it's risky if you risk a clotting of the cannula while you are waiting for the circuits to be ready for the connection. Moreover, this contaminants is probably referred to a contamination from the ends of the person preparing the circuit, or from the ends of the person doing the assembling before use. So maybe just going for an advanced strategy of pre-priming using sterile gloves and using an extended procedure to wash the ends of the person preparing the circuit could be enough to prevent this kind of contamination. So maybe, according to this published evidence, published and studied using a variable kind of circuit, a variable kind of priming solution, and a variable strategy for maintaining and storing the circuit after preparation, it's a non-existing risk. What about the potential for dysfunction of the circuit, which is mostly dysfunction of the membranous lung? A group of researchers study the membranous lung after blood priming, meaning they pre-primed the circuit, they stored the circuit after pre-priming, and then they replaced the priming solution with blood to test the membranous lung function. And membranous lung function, particularly oxygenation, was not affected or minimally affected. And also in the larger studies that I have cited before, Asaia and Resuscitation Plus, the membranous lung function was not affected after ECMO initiation. So pre-priming is safe when assessing the function of the membranous lung. The last risk is the potential for release of plasticizer. Plasticizer, particularly phthalate, are substances that are included in some component of the ECMO system, particularly the tubings and the priming bag made by polyvinyl chloride, because this plasticizer increase the resistance of the circuit, of the tubings, increase the transparency, and increase the elasticity and the resilience of the circuit. So this is good for the circuit, but it's not good because if this plasticizer release these substances inside the priming solution and then to the patient, may be dangerous. It's not so easy to assess for the presence of phthalate inside the priming solution, so a limited number of studies is available with this kind of data. A major one is this by Karimova in 25, so it's an older study. They were not able to detect the presence of phthalate after days of priming, so it seems safe. Another study, again, it's not so recent, found an increased risk for release of phthalate from migration of phthalate from the wall of the tubings to the priming solution and to the circuit when lipids and proteins were used. But this normally it's not something that we do normally. Normally, we don't include lipids and proteins in the priming solution. We just have lipids and proteins coming in touch with the wall of the tubings during the run. And this is something that we can't avoid. But in the priming solution, we normally don't include this kind of substances. The other thing that you need to consider is that if you go to check your circuit, you can find that normally with the circuit that we are using nowadays, we are using this kind of tubings, and this kind of tubings have an acronym, an abbreviation on the tubing, which is no DOP, meaning that they include a different plasticizer, the first one here, TEHTM, which is not able to release toxic phthalate like DOA and DEHP. So it's safer to use this kind of tubing for the patient. And it's also safer when it comes to pre-priming, because these tubing are not able to release dangerous toxins for the patient. So it seems safe. So maybe preparing and priming the circuit in advance could be absolutely useful. And it's absolutely common. But it's safe. This procedure stays off-label, so you should develop a protocol inside your hospital, inside your institution, including a detailed procedure on how to pre-prime the circuit. Try to avoid an excessive manipulation. Try to be cautious. Avoid to include any kind of solution like blood derivatives, and lipids and glucose, which may increase the risk for bacterial growth. And try to protect your circuit after pre-priming. For example, like in this picture here, you can try to avoid the contamination, not at the moment of priming, but also after pre-priming if the circuit is not stored properly, but is stored in a room which is full of people or full of persons touching the circuit. You should not touch the circuit after pre-priming and preparation until you need the circuit for your ECMO patient. In the priming chapter of the ECMO specialist training manual, we included a label to be used for pre-primed circuit, stating the expiring date, stating the type of priming solution, the lots of the devices, and the name of the person who have done the pre-priming. You can download this label, and you can. It's a label that can be adapted to your system, and it's available for free for everyone. Just scan the QR code. So we have a lot of questions. Again, it's an off-label procedures. We don't know the ideal temperature to maintain, to store the system. We are not aware of the benefits of eventually maintaining the circuit circulating or not. Probably connecting the sweep gas flow and connecting the heater unit may increase the risk for contamination, but we don't know these answers. So please try to do research in this field, because it's really interesting for a lot of groups out of there. If we are not supposed to use blood derivatives, and glucose in the priming solution, what kind of solution are we supposed to use both for pre-priming but also for priming? We start normally with a strategy which is named clear priming, which means using a crystalloid solution, an isotonic crystalloid solution for the priming. An isotonic and solution should be a balanced solution, not able to induce electrolyte imbalances and metabolic derangements when it's mixed with the plasma. So this is the plasma. You can see the pH, the osmolarity, the electrolytes of the plasma. And the solution that we are supposed to use for the priming should not be too much different compared to the plasma. Why crystalloid and not colloid? So there is no evidence for benefits in using colloids. There is a lot of evidence of potential harms in using colloids for priming, particularly if you use starches and gelatins. This may increase the risk for acute kidney injury. They increase the risk for coagulation derangement, and they increase the risk for anaphylactic reaction. Moreover, colloids have higher cost, particularly if you use albumin. It's really costly compared to a crystalloid priming. So please go for a crystalloid priming. We have a lot of solutions out of there. We can start with the N of sodium chloride 0.9%. It's commonly used. It's so commonly used that in the English-based country, it is called normal saline. In my country, Italy, it is called a physiological solution, which is absolutely strange because this solution is the most abnormal and unbalanced solution that we can choose to prime our circuit. If you go for normal saline, you have a really high load of sodium, a really high load of chloride, and this may lead to a situation named hyperchloremic acidosis. And the fact that concentrated sodium chloride solution are not so good for the patient is nothing new. This is a study by Cushing early in the previous century. Sodium chloride is bad for the patient. We have a lot of other choices. So please put a red flag or something else beside normal saline and go for something different. We have a lot of balanced solution. Maybe you don't have all of this solution in your centers or in your country, but you have some of this, and some of these are really similar to the plasma. No one of these solution is perfectly matching the plasma, but they have similar electrolytes, they have buffers, and they are good for the patient. So unless you have a specific situation and you go for priming at the moment of cannulation, knowing the organ failure of the patient, knowing the electrolytes concentration of the patient, and you choose specifically for that patient, you can go for any kind of balanced solution for your priming. But sometimes we need something different. We need what is called blood priming, meaning using blood to replace the clear prime. You should first go for the clear prime, then you need to add blood to replace the priming, the clear priming from your circuit, and just connect your ECMO primed system to the patient. What I mean for blood, it could be whole blood, if you are really lucky and you have whole blood in your center. But normally it's something different. It's packed red blood cells with fresh frozen plasma or just packed red blood cells. If you use whole blood or fresh frozen plasma with your packed red blood cells, you maintain coagulation factors and you are able to maintain a higher colloidosmotic pressure, so it's good, but sometimes it's just packed red blood cells. Normally, considering that this strategy is implemented in smaller children and in neonates, the blood that we are using is fresh blood and sometimes also irradiated blood. Why going for blood priming? You normally are supposed to go for blood priming when the hemodilution that you risk to induce when connecting the circuit with clear prime to the children or to the neonate, it's excessive and you risk to damage your patient. So you need to consider the priming volume of your circuit, the blood volume of the patient. There are tables because different weights correspond to different blood volume, depending from the age and from the weight of the patient. And you need to consider the hematocrit of the patient. There is this formula which is commonly used. It's reported in all the books of extracorporeal circulation and also in the ECMO specialist training manual. So you just need to apply this formula. But normally, if you work with the smaller children and neonates requiring blood priming, you know the weight of the patient requiring blood priming without implementing this kind of formula at the bedside. Normally it's below 10 to 15 kilos, then depends on your circuit. Also depends on the setting, because in an emergency setting, normally you don't go for blood priming, you just start ECMO immediately and then you add the blood, because blood priming, it's not so easy. It's a recipe. You need to prepare your clear priming, then you add you need to remove the clear priming from the priming bag and add the whole blood or packed red blood cells. Then you need to add the heparin and sodium bicarbonate. Then you need to circulate the heparin with the blood to displace the clear prime, and then you're supposed to add the calcium to antagonize the citrate of the blood from the blood bank. Then you need to start circulating with sweep gas flow and the ether unit on. You need to recirculate for at least 5 minutes, and then you need to assess with the point of care testing the post-membran lung blood gases to normalize the bicarbonate, to the calcium, to check if you have an excessive level of potassium and eventually potentially go for ultrafiltration, which is not so common if you were able to use fresh blood, and you need also to fix the tension of carbon dioxide. So it's a recipe. It's absolutely not easy. We don't have the time to go into the detail. Again, you can download the for free, scanning this QR code, the checklist for blood priming that we included in the ECMO specialist training manual. But it's not something that you can do in an emergency setting. Just start ECMO and then give the blood through the ECMO system or to the central venous line to the patient. So it's not so common going for a blood priming in our ECMO patient unless you work with smaller children and neonates, but it's definitely common to need to cope with the blood that you have in your system, in your circuit during the run. And particularly when you need to go for a circuit replacement and when you need to go for weaning. So when the ECMO run it's over, you need to decide what to do with the blood that you have in your system. You can choose to discard the blood that you have in your ECMO circuit, and you are going to have a complete whole blood loss. Normally, the modern ECMO circuit have a priming volume between 600 and 700 ml. Then if you replace the circuit, if you add an extension or add any kind of manipulation of the circuit, you can have a larger circuit, but normally it's like having a blood of a bag of whole blood in your system, plus another bag of red blood cells. Discarding the circuit, it's easy. In a few seconds, you can discard the circuit. It requires no manipulation, obviously, and it seems inexpensive. But you need to consider that if you go for discarding the blood that you have in your circuit, you increase the need for transfusion. And transfusion, it's costly. And the blood is something that we don't have always available, particularly if you have a patient with a specific blood type, or if you have the patient who can't receive any kind of transfusion, maybe because it's a religious belief, you need to find strategies to spare the blood that you have in your circuit. And we have this kind of strategy. The easiest strategy is going for a cell saver, which is something that you maybe normally do after CPV. It's going to salvage all your red blood cells. You're going to lose platelets, coagulation factor, white blood cells, and proteins, but you are sparing red blood cells. It requires no manipulation of the system or a minimal manipulation of the system. About the costs, you have the cost of the cell saver circuit, the cost of the bags, but these costs are lower compared to the cost of transfusion. It definitely increases the complexity, and maybe you don't have people in the ICU able to manage a cell saver, or maybe you don't have a cell saver in the ICU. It's easier if you go for a decannulation, for weaning and decannulation in the OR, maybe for a veno-arterial ECMO when you need to repair the vessel. In the ICU, it's not so easy. But we also have other strategies to return the blood from the circuit to the patient. It's a strategy using the circuit, the ECMO circuit, to return in the blood. This is going to salvage the whole blood, because all the blood in the circuit is going to be returned to the patient. So you are sparing platelets, white blood cells, coagulation factors, and proteins, besides red blood cells. You need to be careful because it requires the manipulation of the circuit. So you carry the risk for air entrance and clot embolism, so you need to be slow and cautious. Even if you are slow, you can go too slow because you are still connected with the cannula. And if you want to remove the cannula without leaving the cannula in place for too long after ECMO, you need to use a certain velocity. And you risk eventually for an overload of the lungs, for the lungs and for the heart. So you need to consider if it's safe for that particular patient to go for a blood return with this strategy. And manipulation of the circuit is definitely required. It's a strategy that can be implemented in different ways. We just published it with Professor Peake and Graham McLaren in the ASIO journal, this table with all the different strategies that you can use to return blood from the circuit to the patient at the end of the ECMO run, just using connectors and extensions. So it's really inexpensive. It just takes a little bit of time and a little bit of cautiousness. We can go through all of this, but again, you can download the file using this QR code. And with this slide, I finish my talk. Hope to be in time.
Thank you very much. It was indeed a very, very informative talk with a lot of tips regarding these, I would say, very critical steps in ECMO management. We have Dr. Colliers. You want to make a comment? No, not really. Yes, please. Yes, go ahead.
Okay. A question from me. Supposing that you have a pre-primed ECMO circuit for 2 months with a clear prime, and there is an emergency, are you going to use this ECMO circuit, or are you going to change it?
Absolutely. I'm going to use it. Again, the evidence, the published evidence that we have is up to 73 days, which does not mean that after 73 days is going to be discarded. What we have at the moment is published evidence up to 73 days in a clinical setting. It's not so easy for me to have a circuit, pre-primed circuit for 2 months. Normally, I use circuit for after a short time. But again, if you are able to train your perfusionist in your center to respect some clear rules in washing their hands, I go for a surgical washing of my hands before pre-priming the circuit. I completely gown myself in a sterile gown, mask, hat, and sterile gloves, just to stay safe. It's not required normally, but to stay safe, I use only sterile garments to pre-prime the circuit and to
And what is your protocol in your hospital? What the protocol of your hospital says? How many days do you say it's okay?
We don't have any limitation. We don't have any limitation. The problem is in including a limitation is that if another higher level of evidence is going to be published tomorrow, you're going to miss this kind of evidence. So unless you're absolutely able to be quick in updating your procedures, defining a time limit, it's problematic. Again, I have an high volume in my center for using the circuit because we go for a lot of procedural ECMO, not only conventional ECMO. So I'm safe because normally after 1 week, 2 weeks maximum, I'm going to use the system. But just in case, we are ready to keep the circuit also after.
Thank you.
Please correct me if I'm wrong, but in my mind, pre-priming is useful practically in cases of patients suddenly crashing. I mean, in cases of ECMO CPR, practically, because otherwise, if you have a patient, who's in cardiogenic shock and rapidly deteriorating in the ICU, still you have some time to prime your circuit at that point before you need to insert the cannulas in the next 5 minutes or so doing CPR on this patient, right? I mean, you have a pre-primed circuit just for cases that will need ECMO CPR in the hospital. Is that right? That's the idea.
The pre-primed circuit is the circuit that this is the first circuit that I use. So if I have in a CPR, if I need to go for an emergent circuit replacement or for an elective circuit replacement, or if I have an ECMO, conventional ECMO in an elective setting, the first circuit that I use is the circuit which is pre-primed. And just as soon as this circuit is connected to the patient, another circuit is going to be pre-primed to be ready for the
case of an extreme emergency. Yes. Okay, that's the idea. Dr. Kalaritis, you want to make a comment, I think?
Yes, I do apologize. I'm managing a 1.9 kilo patient on VA ECMO that's imminently going to come off, so I apologize about the delays. I think that having a circuit primed is a standard of care now, I think, in ECMO centers. And I think that as long as there's no medications in it, there's studies now that show that you can have a circuit primed with no medications in it that is good for at least 100 days in your unit. So it is a great safety net to have. based on the patient's hematocrit, you always have the time to add blood or do CRT to crash on ECMO. So you don't need to necessarily add blood in the circuit before going on. As you said, doctor, if there's a chance to optimize the circuit, there's always time. I don't think usually perfusion is a rate limiting step. So there's always an opportunity if time is allowed to optimize the circuit. So yes, that's our practice here in the USA. We leave the circuit, we have a circuit that's always primed, and the studies clearly show that it can be left at near the ICU or wherever you need it for at least 100 days, based on the literature.
It's safer. It's absolutely safer. Particularly, again, in my center, we don't have a perfusionist available 24/7. You need to call the perfusionist, and having the circuit ready is a safety net for everyone. For everyone. Then, if I am in the room before the ECPR initiation, for example, I just modified a little bit the circuit because when I go for an ECPR, I'd like to have a connector on the drainage side to be able to administer blood and fluids to the patient in the ECPR setting, particularly if we don't have a central venous line or another line, but it's just for the ECPR patient. But I normally don't go for a modification of the drainage side because of the risk of entrance. So, but again, it's a modification that I do in the emergency setting if I am at the bedside at the CPR initiation. Otherwise, we just start with the circuit as it is.
Thank you very much, Marta, for the excellent presentation. We are moving forward. We have now our next speaker, which our eminent professor from Florida is Professor Jill Speak. He's well known in the literature for his contribution to the ECMO services, and particularly the ECMO network in UK. So we are very pleased to have you today, Professor.
Thank you very much. Can I have my slides up, please? Fantastic. So I'm going to talk about the ALSO bedside guide. Next slide, please. Please, could I have the next slide? Okay, I can't see the slide. I don't know whether you can.
Let's see if we can make it. Not yet. We're at the first slide still.
Okay, don't worry about it. We'll do it without slides. So let me talk about the concept for this. So Velia has just explained to you a whole load of stuff about circuit priming and circuit components and things. And of course, when we work with ECMO, we're used to lots of different components. Many people work between more than one ECMO center, and so they may have to go from one system to another. Many of us work with patients who are different sizes, so we may have to 1 minute be looking after a patient who weighs 2 kilograms, and then go to the next room where the patient weighs 150 kilograms. And so naturally, there's lots of changing between the patients, and there's lots of information that we might not be able to remember. Next slide, please. Okay, if it's not going to work, just don't bother. Just leave that where it is, and we'll work through it. So when I was, it's better not to distract. Just leave it where it is. Okay, we're going to give up on the slides. Just leave it where it is. So when I was a young man, I was very taken by an English author called Douglas Adams. And he wrote a, can you stop messing about with the slides, please? It's very distracting. Just leave it. He wrote a book called Hitchhiker's Guide to the Galaxy. And this is a story about a man who hitchhikes around the universe after the Earth is destroyed. And he has a guidebook, but it's not a book, it's an electronic guide, and he keeps it in his bag, and it tells him everything about the universe. And this device is called the Hitchhiker's Guide to the Galaxy. Now, of course, this was many, many years before smartphones were thought of. And now, of course, we have our smartphones, and we have the ability to have as much information as we want in the palm of our hands. When I was training as a young doctor, an ECMO fellow, we had a pocket-sized book, which was called the Frank Shan book, which everybody in the English-speaking, or rather in the English-speaking world is familiar with. It's an Australian pediatric intensive care book, and it has every single drug that you might use in children. And it's about this thick, about that tall, and about this thin, and it fits in your pocket. And so you can look up the dose of Lasix and the dose of atracurium and every drug that you might need. So it occurred to me and many other people that actually, as ECMologists, what we needed was a similar app, or rather a similar information base for ECMO that gave us all of the information that we need at the bedside that we couldn't necessarily remember. Now, I would like you all to take out your cell phones, please. Do it now. If you have an Apple phone, go on the App Store and search ECMO Bedside Guide. Did you find it? Can you see the ALSO logo there?
Yes, we did.
Great, so download it. Now, if you have an Android phone, I have no idea how you do it, but I know that it's available on Android. So presumably the same keyword.
You can find it in Google Play, yes.
Yeah. Now, it's free. You can download it. You have to accept the license, and then you'll see the app. And you can see that the app, you have to scroll down to accept the license on each page. And you have to put your email address in to register. But that's the only restriction. And you can see that there's all kinds of information there. There's information about priming volume of circuits. There's information about different components. So you can configure it to work with your circuit. So if you use a CentriMag pump, if you use an AMG oxygenator, you can save that information in your favorites. You can look at the pressure drop across cannulas, all kinds of things that you need at the bedside, but you can't remember. Did you, on the panel there, manage to download?
We're doing so. So
I wanted to show you how easy it is and how accessible. Now, the other thing that you might not be able to remember is the doses of drugs. So there's a formulary there that has the normal ECMO doses of drugs. And of course, the ECMO doses may be different for different drugs that have different lipid affinities. And this is important particularly for opiates. Drugs like fentanyl, which I think is a very bad drug to use on ECMO, can be heavily absorbed by the ECMO circuit. And you'll notice that we don't have every single drug listed, but we do have very many drugs, and we're working on getting further drugs listed as we go along. Mainly with respect, the information in the guide is with respect to how ECMO affects the distribution. We have a section for calculators. So we, for instance, thinking about the priming discussion that you just had with Velia, we can work out what our hematocrit is going to be after we go on, having already worked out what our priming volume is from the equipment part of the guide. There are also a section on ECMO candidacy, so we can look up whether a patient is a good candidate for ECMO. And we also have checklists. So if you wanted to do a circuit change, or if you wanted to take a patient off ECMO, there are various different evolutions which can be done on the checklist. Now, at the bottom of the home screen, you'll notice that there is a red triangle that says panic. And that is the button that you press if you're panicking. So if you're at the bedside and you're a young doctor or nurse or a junior perfusionist that doesn't know very much about ECMO, and you're faced with an emergency, you can click on that button and a screen will come up. Do it now if you've already downloaded. What's the first thing that it says?
Accidental decannulation.
No, that's not the first thing it says. When you click panic, it says something that comes right up.
Oh, don't panic.
Don't panic. So that is not only very helpful advice, this is straight from Douglas Adams and the Hitchhiker's Guide to the Galaxy, and it's what is written on the outside of the Hitchhiker's Guide. Don't panic. So take a deep breath, don't panic, call for help, and then you can click on whichever emergency you have, and it will give you advice about how to deal with it. I would encourage you all to download it and play with it and introduce it to your teams. And I would also now like you to click on the hamburger menu at the top, which will give you the acknowledgements. And if you could click on the acknowledgements, you can see how many people were involved, pages and pages of people. So this is a massive team effort of people that helped to produce this, including Velia, who we heard from just now. And as you scroll down in alphabetical order, you'll notice Dr. Bartlett's name there. This is one of the last projects that he contributed to before his sad death. And yesterday we were in Ann Arbor celebrating his life and achievements. So we owe Dr. Bartlett a massive debt of thanks for inventing this speciality, which has now treated over 250,000 patients successfully. Thank you very much.
Thank you very much. Thank you really very much for this presentation about the new application that it is really exciting, and it is, as you have said, essential. It contains all the efforts from the experts in the field around the world. And we are delighted, even in this country, in Greece, that we have this in our hands, and we will use it in the proximal future. So I don't know if we have any questions about this presentation. I would just like to ask you, we are trying to implement a ECMO training program, and we have included also simulation training program in our hospital. And I find this application extremely interesting. Do you think that will be an additional or even itself a simulation tool for training the new fellows and the interdisciplinary team, the ECMO team, with this application? Do you think that would be a useful or an additional?
Oh, yeah, no, I think that's a great question. And I think simulation, of course, is very important training adjunct. And I was also involved in the development of the Neonatal and Pediatric Foundation course. And of course, there's also an ALSO Adult Foundation course. And people now are beginning to use these foundation courses, which are online, as their ECMO course, rather than develop their own material. And the material is fantastic, both the adult and the neonatal pediatric version. Now, there are deals that can be done with ALSO in terms of pricing if you buy enough of them to match the American Heart Association's price for their CPR training. Now, the sim part of the training is, there's a curriculum for it, and you can use the ELSO sim course and run it yourself and become ELSO endorsed. Or you can develop your own using the same material. And I think using these information decision support things like the Bedside Guide app is exactly how we should be training. The Air Force, and the airlines, various air forces around the world, have been using checklists since the First World War to help them fly safely. And in medicine, Atul Gawande's work demonstrated how checklists can improve outcomes in healthcare. So, I think training like you fight, if you like to use a military analogy, is very, very helpful. So I would encourage you to incorporate this app into your both training and practice, because Einstein pointed out that if you didn't bother remembering everything that you had to remember, you had more brain left for thinking. So if you know where you can look something up, you don't have to remember it. So I think the app is fantastic from that point of view, and we continue to work on it to complete the information, because it's not completely finished yet, but it's there and it's very useful.
If I may ask you something, this is really a fantastic application, and it's intuitive that it's going to be very, very helpful, especially in new programs, junior physicians who have minimal experience with ECMO. The question is there any evidence that actually the implementation of this application, I mean, if a program starts to use this application, has actually improved the outcomes of the patients? Is there any hard evidence of that, or it's just intuitive for the time being?
Yeah, I think that's a great question. I've omitted to mention that ELSO had put in, I believe, multiple millions of dollars to this app to actually bring it to fruition, and I'd like to thank Christine Stead, Peter Rikus from ELSO for driving that. We don't, we've only launched this at ELSO, so we don't have that piece of evidence in with respect to this app. We do have that evidence from many other aspects of medicine, surgery and medicine, from time to needle to stroke medicine to operating room safety. So it's not unreasonable to think that using a systematic approach and an app in this way would be helpful. But I think that this is the kind of thing that is a great idea, and I look forward to reading your paper on the subject when you've proven whether it works or not. So when I did a similar thing to prove that adult ECMO worked, that we published in The Lancet in 2009, it took approximately 10 years from inception to publication. So don't underestimate how difficult that kind of study is. But I think that's exactly what people should try and do, is prove whether it works.
Just another question that we know that artificial intelligence, it is something new, applications everywhere. We know that there is the ECMO PAL prognostic application. Do you think that we can have the support from AI even at the bedside for all these services that we are doing? And is there anything right now being doing in this field?
That's a great question. I have to say I would hesitate to let AI decide about my patient. I'm currently consulting several different units around the world, in fact, who have got patients who have been on ECMO for a long time and who are wondering whether their lungs will recover. And, you know, the answer is we don't know. But it's very easy to find stuff with AI that says, oh, no, they won't recover. But equally, I can show you many patients that I've looked after whose lungs have recovered after a significant amount of time. So I think that AI is, you know, going to be here to stay. I think it must have a place in medicine, but I think we should be careful about trusting it too much. So we did a study looking at time to adequate anticoagulation using AI versus using common sense. And the AI could do it better than people could. And I think that's the kind of thing that we should be investigating, whether we can use AI to adjust the dose of bivalirudin, that kind of thing. You know, I think there's still a place for common sense and experience, but I'm sure that in the future we'll have AI decision support in all kinds of areas that we can't even dream of right now.
Thank you very much. Really enthusiastic. Athina Ramu, our chief perfusionist, will like to ask you something.
As a perfusionist who works in a hospital not very busy, we have ECMO system, but we don't use it very much. I would like to thank you because an application like that is a really reminder in a case that we need to implement ECMO in a patient. And when I first saw it, I was really enthusiastic and glad that we have in our hands a tool like that. So thank you, Dr. Peak.
Thank you.
Thank you very much again.
Dr. Peak, if I could just quickly mention, there's definitely studies on the cardiopulmonary bypass and how the checklist has improved the safety. And if we could use that kind of like tangent for ECMO, I think it's definitely a big benefit. Remember, it's a low use therapy. And when you don't use something very often, it's easy to forget things. So I think this is tremendous work, and I congratulate you not only for this application, but winging your presentation without slides. So congratulations.
Thank you very much.
Great. Thank you so much. It was really, really fantastic. I think it's time. We're already running a little bit behind time for our last presentation. So last but not least, we have the pleasure to have with us Mrs. Dani Tost, who is the CEO of a company called Livemedia. I looked a little bit before I came to your site in the internet. It was really amazing. A Barcelona-based deep tech company transforming healthcare professional training with immersive video games and gamified virtual simulators. That's really intriguing. So we're looking forward to see how, with your software, can enhance training for ECMO application. Thank you so much for being with us.
Thank you very much. I'm pleased to be here, so I'm gonna share my screen. Can you see my screen, or I want to share my screen, please?
You have to try to share your slide presentation, please.
Well, I want to share my screen. Actually, I have. I open my Canva. It's here. Great. Okay. Can you see it right now?
Yes.
Yes.
Perfect.
Yes, we can.
Perfect. That's great. So I'm going to go back. So thank you very much. It's a real pleasure to talk to you today. So I'm Danitos from Diamadex Virtual Experiences, and we are a company, a deep tech startup. We are located in Barcelona, although we have part of the personnel in the United States. And our core technology is the creation of immersive gamified simulators. Specifically, we have two in the market. We are going to talk about that: VRCPB for heart-lung machine and VRECMO. And our mission is to elevate ECC education through accessible and high-impact virtual simulators. This is the kind of projects that we do. So simulator for heart-lung machine, simulator for ECMO, preparation of these kinds of intervention, and also assistance of the patient. Currently, in the market, we have VRCPB, VRECMO, and a third product, which is DEX, which is an AI assistant that we have specifically trained for ECMO and CPB concepts, and that you can use by now outside from the games, from the simulators, but very soon inside the simulators. And this chatbot has been trained with a set of bibliography, restricted set of bibliography, and also with for the calculations, because as you know, some AI don't do very well how to do the calculation. The calculations are programmed at the side. So whenever you ask it a calculation, it does it exactly without what we call in the AI field hallucinating. Okay, just let me start a little bit with the importance of simulation. It has been demonstrated. I think that I don't have to prove it to you, but let's just give a small number. Simulation-based training improves clinical performance. This has been demonstrated up to 20 and 30. And the more devices we use, the more technology, the more is the impact of simulation-based training. What are the advantages? Of course, it increases the knowledge, but it also increases or can contribute to enhance soft skills, communication, decision taking, problem resolution. The idea here is to reduce the learning curve steepness, and this is very important, and this matches pretty well with what you have just explained. It allows people to be exposed to, trainees to be exposed to multiple cases, and specifically to rare and critical cases. So if you don't have the occasion of doing a lot of heart-lung machines or a lot of ECMO, simulation is a way of keeping very well aware of what can happen and keeping trained. The idea behind is the more repetition and error you do, the more you learn. But of course, you have to learn through repetition and error in a controlled, very safe, this is the most important thing, patient-free environment. So in this slide, what I want to show you is a little bit what we call the continuum of simulation. So on one hand, you have apps that allows to, not in the field of ECMO, but yes, in the field of other specialties. There are a lot of companies devoted to do kind of games to learn how to diagnose, quizzes, gamified quizzes. Then we have what we call the simulators. And in simulator, there is a continuum between purely physical simulator to purely virtual simulators. And in between the physical simulators and the virtual simulators, we have augmented or hybrid simulators. In physical simulator, you have these mannequins that substitute the behavior of the patient, and they are very important because you can train you can train also psychometric skills. And here we have a lot of companies, and especially in the field of perfusion, we have Orpheus, Eng & Flow, Califia, and others. Maybe these ones are the most well-known. The advantage of physical simulation is that you are really in a physical scenario and you can train your motor skills. But the inconvenience is that you cannot do it in a very frequent base. It requires a lot of maintenance. It requires a special place, a special setting, organizing a calendar. So it's great, but not everybody can afford it. And so it would be good if it could be complemented by more virtual simulations. In the intermediate place, we have augmented simulations in which the patients are virtual, but the commandments are haptics that allow you to train these motor skills. And in the field of purely virtual simulation, which is where we are now in Virmedex, you can have all kinds of scenarios that are purely virtual. The advantage here is that you can train from anywhere, anytime, as many times as you want. And so it is cheaper and complementary to physical simulation. So our idea is if you train in a virtual simulator and then you go to a physical simulation, you are more prepared and you can take the most of a physical simulation. Within the field of virtual simulation, there are a lot of companies, but specifically in the field of perfusion, there are only 3. A French company that does only ECMO, an American company that does also only ECMO, and ourselves. So we are unique in having a CPB and ECMO VR and laptop solution. Practico Santé is only laptop and NPark is only VR. What are the advantages of our solution? We promote active training. So we transform passive observations into active participation. It's patient safe. It's very easy to use. You just need a connection to internet and a computer or goggles if you want to have a more immersive situation. What's the advantage of an immersive training versus a laptop? Basically, in our case, it's the same, but of course, with goggles, you have more the sensation of being there. But in a daily routine, maybe it's sometimes easier just to work with your laptops. It is affordable in the sense that you don't have very heavy cost of infrastructures and maintenance. And in the case specifically of our simulator, what we have done is we are using the technology of the video games to bet on what we call the gamification mechanisms, the games mechanisms, because it has been demonstrated that the game mechanism which are scoring, feedback, challenges, and so on, they drive continuous improvement because they are based on challenging. Challenging is the most important motivation. Challenging with oneself or each other is a very competitive motivation factor, and it has been demonstrated that through competition you learn more, and what is more important, you learn for more time. You learn for longer. And an important thing also is when you do a virtual simulation, you can track every movement, every action that the user does. And this is a very relevant information then to be analyzed a posteriori for the debriefing, or to understand what has happened here and personalize, customize the training program to the progress of the users. So here you have some numbers. I'm not going to tell you more, but just to know that this is not something that we invent. A lot of people in the world are very prone to use VR technology and laptop virtual technology to train their personnel in the hospitals and, of course, in the universities. Let's enter specifically in our tools. So what provides the Virmedex platform? It's cloud-based, so you connect through the internet. It's global, so you can connect from anywhere in the world. It has data protection, or what you do is encrypted and protected, 24/7 access, compatible with VR glasses. And important thing, we have like two roles, what we call the teacher role, which is like the supervisor role, that has access to all what his or her students do, and the student role, who has access, of course, to the simulators, but also to its own results, but only to its own results. So here we can see cloud-based, VR and laptop. This is the aspect of the platform. When you enter, you have a training program that is constantly evolving, in which we add constantly new tasks. So you press on a task, and you have to do it a certain number of time, and you earn. This is why it is gamified. You earn points of expertise as you are doing this training program. The order is important, and actually the different simulations are locked unless you do the previous ones. So it's a level-based training program. It is gamified, and within this training program, we also integrate quizzes. So the practice is alternate with theoretical knowledge, and it has been also demonstrated that alternating practice and theory is also a way of fixing the concepts. So once you choose an activity, for instance, a quiz, here you have quizzes with time, without time, and of course we register all the results, but you can enter in a simulation. For instance, this would be a simulation of your CPB. You enter here, and what you have to do is conduct parts or an entire CPB intervention with many incidents that can occur inside that. So this, I have already talked about this, and this would be an example of how is it in the ECMO setting. So important, we have a variety of patients with different weight, different sex, of course, different ages, and this changes in every game. And every different way also. And what is important, these patients have different physiological variables, so they have different starting conditions, and there are different points in the case of the ECMO of the ECMO process. So you have to manage with the last analytics that we got from them. You can ask for new analytics, and so it's really behind our software, we have a realistic physiological model. So if you raise the ECMO pump, what will happen is that you will have more or less, well, in this case, more oxygenation. If you change the gas blender, the corresponding PCO2 will change, and so on. So your actions have an impact on the variables of the patient that you can see in the different monitors. And this is free in the sense that you don't have to follow a predetermined scenario. So it's not going from 35 to 36. No, it's the most similar as it can be to the real life. Once you finish playing, you have here your board in which you have exactly all the simulation that you have gone through with your scores. And if you press here, you can have the debrief of exactly what you have done. You did this correctly. You did that incorrectly. You answered correctly these questions, or you delayed too much this answer, and this kind of things. So this is the summary of what we have. What is the insight? So what are the contents of our simulators? So we have based the contents of our simulators in this view of what is really, what is needed in ECC, what are the skills and attitudes that are important to train. It's a circle in which you need clinical knowledge, you need monitoring constantly, you need procedures, following procedures, having checklists, you need communication with the rest of the team, you need to solve problem when there is a problem, train the resolution of these problems, checking again what you have done, if your resolution was correct, if the resolution that you proposed was correct, improve procedures, and finally research. So what we are, share your improvements with the rest of the community. What we have tried to do here is to work on these stages, on the clinical knowledge, the monitoring, the procedures, the communication, and the resolution. Specifically for the ECMO training, we address the circuit component, the blood gas interpretation, the VV ECMO management. VA is on the way, but it's not yet published. The blood gas interpretation, the teamwork and communication, and several troubleshootings. And we have also another program for CPB, including all these kind of things.
Look around the room and examine any equipment you see. I'll explain its purpose and how it contributes to patient care.
So this
You
is
have
an
5 minutes to
example of
explore
what
at
we
your
can
own
see.
pace.
We
There's
are
no
going to
set
see
order.
little pieces of tasks connected. So in the ICU, we have 4
The ECMO
rooms.
machine pumps blood, adds oxygen, and removes carbon dioxide, acting as an artificial heart and lungs.
So this is a very preliminary task in which you just want to know about the different components of the ECMO. So you enter in the IC room, in one of the IC rooms, and here what you can do is touch the different devices, and here the staff will explain you what it is. So here what I've done is touching the oxygenator, and he has explained me what. Here you can see the toolbar. You have different tools that you can do in order to move around, because not everybody knows how to use a video game. So in order to move quickly and easily, you can just go here and you are teletransported to a specific place. So you don't need to have any skills as a gamer to use that, any skills. And here you have different tools to ask for a blood gas analysis, to all kind of tools. We are going to see that. Oh, sorry.
Look around the room and examine any equipment you see.
A little bit further.
5 minutes to explore at your own pace. There's no set order. The ECMO machine pumps blood, adds oxygen, and removes carbon dioxide, acting as an artificial heart and lungs.
So these would be two examples. What is one thing, what is the
From the
other?
gas blender to the ECMO machine. Hello again.
This is another
Today
task,
we're
a
going to
different
test
task.
your knowledge
Once
of
you
the
have
key
done
elements
this
in
and
the
you
ECMO
have,
setup.
you know what are the
I'll
different
ask you questions about them, but be careful. You can lose
instruments,
points for wrong answers or delays. Can you
then
touch
it's
the
your
lower port
turn.
for sampling blood before oxygenation?
So now it's the other side. He asks you to touch the different
Good.
devices and what they are used for. We are now going to,
What
so this is the
name of
very
element
beginning.
that is blinking now?
As you can see, in each task, you have a different patient.
The ventilator.
So very basic starting. Then we have, so this is an example of the training program. Then we have other initiation tasks. In this task, what we want is the user to learn the basics
Today,
of the
I'll
ECMO
explain
management.
the
So
main
there is
features of
not
the
a
ECMO
real
monitor.
patient here. What we have here is a mannequin,
ECMO screen
just
to zoom on.
to not be stressed
In
and
the
to
upper row of the
practice.
screen,
And
at
here
left,
we
you
learn
can see the ECMO flow in liters per minute.
what are the values,
At right,
the relationship
the pump spinning speed
between
in RPM.
RPM, and
You
for
have to
the,
titrate the RPM to achieve a certain flow. To increase or decrease the pump speed, use the up and down arrows at the bottom right of the screen.
so here you would
As
train
you can
and
see,
see,
increasing the RPM
just
results in a
practice, because we don't
corresponding
have a,
increase in flow rate.
let's say, real patient. We can
And
train
decreasing the
and understand the
RPM leads to a
relationship
reduction in flow.
between the different things
Always pay
and
attention
learn
to
the real
RPM
value.
versus
Learn
flow.
how should be PR,
A reduction
how
of the
should be
flow with
delta P,
unchanged RPM
how
indicates
should
an
be
increased afterload resistance.
P-VEN, and so. I'm going to be a little faster.
Oh. Today, we'll work on oxygenation.
Again,
So, focus on the patient's PaO2
introduction
and SaO2.
tasks.
I've disconnected all the alarms.
So here
So
you have
you're
to
on your own to detect eventual problems.
look at the monitor. We will also look at the data of the
I'm ready.
patient.
Look at the patient's monitor. How is the oxygen saturation?
So you have
The
to answer
saturation
this
is very
way.
low.
Of course, if you make mistakes,
Check
you
the
will
patient's
lose
data.
points.
Has there been a change in the oxygen saturation since the last ABG?
So let's go there. And this changes every time. So the patients are every time different. So you have to check the data, answer.
Yes. It has decreased in the last few hours.
And here you will
I
know
see.
how to improve the
Order
oxygenation
an
rate.
arterial blood gas analysis, please.
And then after a while, you can see the results, understand, and see the trend. What
How
is the trend?
PaO2?
So if we look at PO2, it has been decreasing exaggeratedly, so we will have to solve this problem. I'm going to go a little bit faster. So you have a set of tests in which you learn the basics, then you go on your own without incident, and you have to manage all the process. This would be the case.
Today, you'll have a chance to put your skills to the test.
So here, the oxygenation seems, it's fast, huh? So I will go fast. Huh? So you check everything. At the end, when you decide that everything is fine, so you look everything, you go, and now she will tell you what you have done well and what you have done bad.
Oxygenation was good. You correctly did nothing about it. And it's still good. Well done. Now, about ventilation. PaCO2 was above 45 millimeters of mercury. You correctly increased the sweep gas flow to lower it. PaCO2 can be further improved. But you were right in changing it slowly. It's important to avoid rapid changes of PaCO2 in order to prevent brain injury. We will wait, see how it evolves, and adjust more the sweep gas flow if needed. Good job.
Here, of course, she did well, but if she had done badly, she would have got a game over. And here you can see what happened. Huh? And finally, you have several troubleshootings. Actually, we have more right now. We have trouble with the oxygenator, so blood clots in the oxygenator. We have a problem of hypovolemia. We have problems with the oxygen tubes disconnected. We have a problem of pump failure, and also a very simple issue. The ECMO machine is disconnected also, and you have to fix it because you detect that it isn't connected. And this incident specifically is a case of high delta P, evolving high delta P. So
I'm ready.
Through the dialogue, you will see.
Yes. What's going on? The difference of pressures, delta P, is high. I see. Check delta P's trend in the patient's data.
Always about looking at the trends, and I'm not going to bore you anymore. Just this is what I wanted to show. We have all kinds of incidents, and we are constantly working on that. And basically, this is it. Just a small view of what is the CPB program. So we have heparinization, preparation of CPB, all kinds of tasks again. And in this case, it's the goal here is to manage the CPB machine with all the process. Here you have heparinization and all kinds of incidents.
What? This heparin is expired.
From a heparin expired to problems in weaning. And that would be it. So for me, I think I have demonstrated a little bit what we are doing. And I don't know if you have any questions. If not, thank you very much.
Thank you so much for sharing it with us. Are there any questions or comments, Dr. Dimopoulos or Athina? This is actually a software, a simulation software that needs to be purchased by a hospital, I think, right?
Yes.
So that can be used. So does it need to be purchased for its hospital that is going to use it, or can it be purchased by the National Society of Cardiothoracic Surgery of Greece and be used by all the hospitals? They have an ECMO program in the country.
Sure. What our business model is we sell. We create courses. So in a case like yours, we would create a course for each institution within the society. So you could distinguish the data of people from one hospital to the other, which is also relevant for statistics things, but the provider, so who pays the fee, we don't care if it's one hospital or a set of hospitals or an association of cardiology. For us, it's perfect.
Okay, that's interesting, because it would be, I guess, difficult to convince the administration of my hospital to buy it. I don't know what the cost of it. Obviously, I'm not asking you to give me the exact price right now, but I guess it depends on a lot of factors. But it's not going to be easy for just one hospital to buy it in my country, unless, of course, it's an Onassis Cardiac Surgery Center. These are people. I don't know whether some Dr. Koutoulas is asking actually about the cost approximately. Can you tell us a number, an approximate number?
Yeah, it depends pretty much on the number of users that we need. The users are individual, so we don't want to cross data from one user to the other. So each user has an account. So you log in with your specific account. We cannot share accounts, otherwise the data wouldn't be correct. And so we have a constant fee for the organization, and then a fee for each student. Let's say it's this word, and the fee per students are around $300 US dollars. But this is something that plus a constant fee for the organization, which covers the profile, the role of the teacher, plus the teaming, the onboarding session, whatever is needed, and the maintenance of everything. So it depends on the institution and the number of users. Counts like if we share the constant cost, it would be between 300 and 500 per license.
Okay.
Per year.
Great.
So it's not very expensive for 1 year.
For 1 year.
It's not very expensive. In comparison to other simulators, it's very cheap.
Very cheap. Okay. For further information, please contact Livemedia, right?
Sure.
Okay. Are there any other comments or questions? If not, thank you so much for your presentation. And
thank you.
I'm sure there will be a 2.0 platform in the near future, because these things keep getting better and better all the time. So we're looking forward to it. Thank you so much. Thank you.
So we would like to thank all our excellent speakers for their excellent presentations. We have learned for sure new things tonight. I would personally, and on behalf of the panel, thank the organizing committee for this excellent webinar. So thank you very much.
Thank you all for your participation, and we are looking forward for the next seminar on the 25th of February. Have a good night.